bunch of junk in our lungs, pneumonia. And so we would have a dense sound over at atelectasis areas because they're filled with fluid or junk. And so when we go cuss over that, it's going to sound dull versus that high pitch like a drum up here where there's air behind those, okay? And so percussion works for that. The other thing it would work for is sometimes patients develop pneumothoraxes, and it would be a very high pitch, and so you would be able to hear that. While I'm here, I'm also going to check his tenting, and usually I check that around the clavicle because most of the people in Hot Springs are just old. All you have to do is go to Walmart and know that. What would you say the average age in Hot Springs is? 40. It's nice to know what you consider to be old.
Oh, 40?
What's her name? Just put a big old F by her name. You're thinking 40 is old? I once thought 40 was old too, but I have changed my mind on that, and I think that I can change yours.
I mean, it's double my age, so it's a little old.
You're 20?
21.
You're 21.
Yeah.
You're digging a hole.
I see a time when you don't see 22. I'm talking in their 70s, retired. They're very, very elderly, and as you get old, your skin loses some of that ability to bounce back that it once had. And so, yes, on a young person, you can pull the skin on your hands. Go ahead. Pull the skin, and it will go bounce right back. Now, you'll notice on Miss Junkins, it just stays up. Because age has determined that it happened. But in an elderly patient, it may stay up there. You won't notice it that much here. Okay, if you do it right here around the clavicle area, it should bounce right back like it should. So with elderly patients, I usually check there. All right. The other thing I'm going to look at, I forgot to tell you about this, to look at the sclera. The sclera should be white. In African Americans, it may have a muddy look to it as they get older, but the sclera should be white. Now I'm going to look at his abdomen. At this time, I'm going to do things differently. Usually I looked and then I listened and then I felt, I did some palpation and then I listened. In this area here, I'm always going to look first, then I'm going to listen, and then I'm going to feel. Why?
Because you don't want to mess it up.
Well, I don't want to mess it up, that's true. They came in already messed up, don't need to do anything else.
You might change what you hear.
You're going to change what you're hearing. When you start moving around along the bowel, they may start to have some peristalsis, and then they may have to go to the bathroom, so we don't want to do that. All right? So I'm going to look, and his abdomen looks flat, and it's a little hairy. Okay, so it's flat. Does he have any bulging areas, like if he had a hernia? This should tell me when I look at it. The next thing I'm going to do is listen. And what I want to hear is gurgling. Now, you can listen for 2 minutes. If you hear like 3 to 5 in the 30 seconds, then that's considered normal. However, if I don't hear anything, supposedly I should listen for 5 minutes. If you ain't heard anything after 2 minutes, you ain't going to hear anything after 5. But you go right ahead and go at it. And I'm going to listen into 4 quadrants. Some books will actually tell you that there's 9. I believe the RNs, the ADNs, and the LPNs use 4. The BSNs would use 9. And what I know I don't have it in my ear. Because I can't hear myself talk. And I'm going to listen. And then I'm going to write down what I see here. The next thing I'm going to do is percuss. And once again, I'm going to get a seal. And I don't hear hardly anything, and he's fine. But you notice over the liver, it's going to be a little bit duller because the liver is a very dense organ. And so when you percuss over the liver, you're not going to hear much of anything. When was the last time you had a bowel movement?
Last night.
Last night? Did you go to the bathroom earlier? I'm going to palpate his bladder while I'm down here. And he's going to tense up because he's manly and he wants me to think that his bladder is tight. That really has nothing whatsoever to do with the manliness, but okay. It makes him feel better.
I'm very proud of
He has very manly, very manly bladder. For you guys, he paid me to tell you that. I'm going to check his pulses. And I'm looking to see whether they're bounding, whether they're normal, whether they're weak. If they're bounding, I can't obliterate them. If they're weak, they're easy to obliterate. And if they're normal, they just can be obliterated, but not easily. Now, if I was going to do a focus assessment and I was in a hurry, would I have to feel all these pulses? No, because if they've got a radial pulse, it had to come from somewhere. And so, to my knowledge, as of yet, they don't jump over the brachial and come down to the radial. So if I feel the radial, I can assume the brachial pulse is present. However, if I'm not feeling the radial, or if the radial is weak, then I want to determine, where does this weakness come from? Where is this decrease in perfusion happening? And then I would move up. If I can't feel a pulse, what can I do? Get a Doppler. And you need to write that you had to hear it with a Doppler, all right? Because you need to know that there's blood flow. Don't just go, okay, Sarah, I'm going to write down nothing, and then later on when they have to chop off your patient's hands, you start to feel kind of bad about that. I'm going to ask you to bend your arm, put them out, do this, fly like a, that's not part of it, okay, put them down, and so I had that on the abduction, and I know that his range of motion in the shoulders is fine. Now, if you're going to do femoral pulses, you're going to not put it through his pants, and I'm not going to check his femoral pulses because I think that may be a little too much for him. I would wear gloves because you're in that groin area, and trust me, you just want to wear gloves. Especially in the elderly, sick population, because they may not be as clean as you want them to. It's not that they're dirty, it's just that they just didn't care. They felt so bad. And so I'm going to check for his femoral pulses right here. You can check them on yourself, right into the groin area. And what you can do is you can have him put his hand, don't. Or a woman can put her hand under pubis, and then you can have that triangle, and it's right here where you can feel the femoral pulses. The second one would be the popliteal, which is underneath the knee. So what I do is I have him put his leg out on the bed. I put my hand, my fingertips in the gash of his knee, and I tell you just to bend your foot a little bit, and it'll easily fit right in there, and then you can feel the popliteal. That one takes practice, guys. And in some patients, it's almost impossible, depending on how big they are, how bad their peripheral circulation is. So it determines whether or not you're going to actually feel that one. But I still got these feet here. These are cute. Oh my God. What did you do? Bend your foot? Wait, you don't want anybody to see the chickens. You got chicken socks.
I got a chicken sock.
Wait, your socks don't match.
That's the style.
Okay, I'm going to tell you, that's got to do with mental health, and I'm not teaching that. That's a whole different assessment. But when a man comes in with a pink and blue chicken sock, and the other one has got boxes on it, I say to myself, self, it's time to get the mental health assessment out and take a look at that. Okay, bring up these chicken socks. Amazon.com, $1.99. You can get 10 of them, includes the boxware for free. Okay. When we feel for the posterior tibial, think about it. It's posterior to the tibial. So it's not the one on the top, it's the one behind. And it's right behind that bone. And he's got a good one. It's very sweaty, but he's got a good one. And when I talk about the dorsalis pedis, I'm going to go on the top. It can be a little bit different. Sometimes you may have to go lower. Sometimes you may have to go higher. You may just have to feel around till you get it. If I have both of these, then the popliteal and the femoral have to be present. Like I said, they don't skip. I may require medication after this. The other thing I'm going to look at is edema. All right? There's two types of edema. There's that shiny, non-pitting edema. When we have edema, when we press down into it, if it's pitting, it'll pit. It'll stay there. And what we're looking at to see is how long does it stay in there, down. Do they pit it here? If they're greater than 6 millimeters in 6 seconds, then it's like 2. It's greater than that, it's 3. I want to make sure that I cannot pit that. Why am I worried about edema, pitting edema? It's usually a sign of right-sided heart failure. Because when the heart backs up, it backs up into the extremities. Now, can it be a sign of left-sided heart failure? Yes, but that's severe because it's already backed up into the right side, all right? But actually, it's the right side is dumping fluid into the extremities. Now, it's usually caused a right-sided failure, but if you have such bad heart disease that it's flowing backwards, you can have that anyway, all right? I've had a patient that had such bad edema, it actually leaked out of their skin, and it's not necessarily always right-sided. So I want you to understand you can have pitting edema from left-sided heart failure, but by that time that happens, that's pretty bad, okay? It's already backed up from the left and into the right. Non-pitting edema, it looks like it's shiny. It doesn't pit. It just looks swollen, all right? And so that can be indicative of other things, some kind of renal diseases, some kind of liver diseases, injury, and so be aware that that's a little bit different. Once again, I'm going to look at his pedal not his pedal pulses, his capillary refill without the pink socks. And I'm going to see whether or not it should be less than 3 seconds. What happens when my patient's got nail polish on? Well, yeah, you can check the top of their toes. Or you can take the nail polish off. Sometimes that's a little bit harder. I'm going to check for his strength. Can you move your leg up? Can you push your leg down? Can you push your leg up? Yes, show off. Can you push your hand down? Can you pull your feet up? Okay. He's got equal strength. Can you put this leg to the side? Back? Like this. I'm 60 and I can do it. Come on. Stand up and do it. You're just bad. It's that sock. And while he's up, I'm going to look over here and make sure that he doesn't have any skin breakdown. Now, when I check the skin, you can get back on your perch. When I check the skin for temperature, what part of my hand am I using? Dorsal part, the top. I want to make sure, because it's the one that has all the vessels in it. Look at your hands. So it's actually going to feel that temperature a lot better than the palm of your hand. However, when I'm looking at certain things for like African American people, when I'm looking at color, I'm going to look at the palm of their hands, I'm going to look at the soles of their feet, and I'm going to look at their mucous membranes. Because some of the things that I would look at could be ambiguous. Like I said, sometimes their eyes will change to that muddy color, and you might think they're jaundiced yellow when they're not. Patients who are African American and, let's say, Asian, they may have a pallor when they become cyanotic, whereas the Caucasian will become blue around their lips and in their mucous membranes when they're cyanotic. Which brings me to this point about perfusion. I don't know whether or not you learned this or not. There's more stuff up here than when I started. There's a difference between somebody who's not breathing well and not oxygenating well versus somebody who's not perfusing well because they have a clot. So let's say you have blue nail beds, okay? And you say to yourself, well, they're not breathing well. But that's not necessarily the case, because what else could keep blood flow from going to your extremities, like your feet? Clot, right. And so when you look at things, you need to determine, is it oxygenation or is it perfusion? Oxygenation is usually around the mouth, okay? Whereas perfusion will show up more in the extremities. So if your patient is having an oxygen problem, you're going to see it around the mouth, what we call central cyanosis, that blue or pale in African America, in the mouth and in the mucosa of the mouth. Whereas you're not going to notice it so much in the nail beds. If you have a good pulse and you have blue nail beds, what does that tell you? It's probably oxygen, right? But if you don't have a pulse, then it's perfusion. And so you can't just decide that your patient has poor oxygenation just because he has a blue tinged fingernail. You need to see whether or not the pulse is good. And if that's the case, does your pulse oximeter work? So you got blue nail beds. Is your pulse oximeter going to actually work? Probably not. If it's a perfusion problem, you're not going to get a true pulse ox. And so if you have bluish nail beds, you need to determine whether or not that's caused by not enough blood going there, or is it not enough oxygen going there. It's basically the same thing, but one's caused by a clot or an obstruction, and the other one is caused by a lung problem. Did I miss anything?
No, ma'am. Great.
You would have said that no matter what.
Well, it was great. Thank you, Miss Brown.